Okay, let's unpack this. You know that feeling. You're trying to get your head around a topic, maybe for revision, maybe just, curiosity, and there's just so much information. Notes, articles, it can feel like trying to build something complicated without instructions.
Absolutely. That information overload is real,
Mhm.
especially with medical conditions where the details really matter and how they all connect is just crucial.
Exactly. So today we're tackling one of those. We're doing a deep dive into Korsakoff's psychosis. It often gets mentioned alongside Wernicke'sencephalopathy as part of Wernicke-Korsakoff syndrome.
Right, and we're working from a set of pretty detailed revision notes you shared, focused specifically on this condition.
Yeah, think of us as sort of guiding you through those notes. Our plan is to pull out the really key high-yield stuff and give you a clear picture of Korsakoff's psychosis, what it is, what causes it, what it does to the brain, how it looks, diagnosis, management, the whole deal.
And it's fascinating, isn't it, how something like, well, diet can connect so profoundly to memory, to personality. You had to piece together clues from different angles.
Totally. And it's tied to a deficiency that's often linked to something really quite common. Okay, so first things first. What is Korsakoff's psychosis, fundamentally?
Okay, so at its core, it's a neurological disorder. And the absolute root cause is a lack of vitamin B1, thiamine.
A vitamin deficiency causing major brain issues. That sounds significant.
It is. And it's important to know that Korsakoff's psychosis usually isn't the first stage you see. It's part of this broader condition called Wernicke-Korsakoff syndrome, or WKS.
Okay, WKS, the umbrella term. So what's the first part, the acute bit?
That's Wernicke-encephalopathy. Carl Wernicke described it way back, 1881.
And what does that look like? What are the key signs of Wernicke?
Well, the notes point to a classic triad. You've got encephalopathy, basically brain dysfunction, confusion, altered mental state. Then oculomotor dysfunction problems with eye movements, like paralysis or weakness. And third, gait ataxia, trouble walking, unsteadiness.
Confusion, eye issues, difficulty walking.
Right.
That's Wernicke's, the emergency phase.
Precisely. And Korsakoff's psychosis. That tends to be the later stage, the chronic part. It often happens if Wernicke's isn't spotted and treated properly quickly. And the absolute hallmark of Korsakoff's is severe global amnesia, just profound memory loss.
Severe memory loss. What does that actually mean for someone living with it?
Well, it shows up in a few key ways. There's severe anterograde amnesia. They really struggle to make new memories. Stuff that just happened doesn't stick. And then retrograde amnesia, losing old memories, sometimes stretching back years before it all started.
Wow. So they can't build a future and they lose chunks of their past.
Yeah, and tied into that is amnesia of fixation-like,
Yeah.
difficulty holding on to information even for a few minutes. And then there's confabulation, which is really striking.
Confabulation, what's that?
It's where they sort of fill in the memory gaps by making things up, unconsciously. The crucial thing is they genuinely believe these fabricated stories are real. It's not lying.
That sounds incredibly complex, believing your own invented past. Any other cognitive things?
Oh yeah, attention problems, difficulty concentrating, disorientation, confusion about time, place, who they are. Lack of insight is common too. They often don't realize how bad their memory problems actually are. And sometimes apathy, just a lack of interest or emotion.
It sounds like someone completely adrift.
You'd think so, but here's a curveball. They can often maintain pretty normal social chat, superficially anyway. This can actually hide how severe their memory issues are at first glance. They might have a pleasant conversation, but, 5 minutes later, no memory of it.
Huh. That mismatch between seeming socially okay and the underlying memory loss. That's a big clinical clue, isn't it? And you said physical signs can linger from the Wernicke's part.
That's right. Things like walking difficulties or eye movement problems, like nystagmus, that rapid involuntary eye flicker can carry over into the chronic Korsakoff stage.
Okay, we've got the symptoms. How do clinicians actually diagnose this based on what you've described and their history?
Well, the diagnosis comes from seeing those characteristic symptoms in someone who has the risk factors. The criteria usually involve finding that anterograde and retrograde amnesia, the fixation issues, the confabulation, lack of insight, maybe apathy. And you look really closely at their history for things like, obviously, chronic alcohol use, but also other potential triggers: chemotherapy, dialysis, major weight loss, low BMI, anemia, even other nutritional issues like pellagra.
Right. So the main cause is this thiamine deficiency. But what causes that deficiency? Who's most likely to get it?
The big one, the most common cause by a long shot, is chronic alcoholism.
Is that just because heavy drinkers might not eat properly?
That's definitely part of it. Poor diet means less thiamine intake. But alcohol itself is a double whammy. It actively interferes with how your gut absorbs thiamine, and it messes with how your body actually uses the thiamine it does manage to get. So it's not just poor intake, it's active interference.
Ah, okay. So alcohol specifically works against thiamine, but it's not just alcohol, is it?
No, definitely not. While it's the usual suspect in many places, other things can lead to severe thiamine deficiency, serious malnutrition, for any reason, really. Conditions like hyperemesis gravidarum, that's severe vomiting in pregnancy, GI disorders that stop nutrient absorption, certain cancers, chronic dialysis, even things like AIDS or severe heart failure that cause prolonged nutritional stress.
So the risk factors really boil down to anything stopping you getting or using enough B1. Chronic alcohol use is number one, but also severe malnutrition, problems absorbing nutrients, and some serious illnesses.
Exactly that.
Let's circle back to the brain damage. You mentioned where it happens: medial thalamus, mammillary bodies, hypothalamus. But how does not having enough thiamine actually damage these bits? What's the pathophysiology?
Okay, so thiamine is super important. It acts like a helper molecule, a cofactor for key enzymes that help our brain cells get energy from glucose. You mentioned that pyruvate decarboxylation earlier.
So without thiamine, the energy production in brain cells just slows down or stops.
Pretty much. In simple terms, it disrupts how the cells metabolize energy. And those specific brain areas involved in memory seem particularly sensitive. Maybe they just need more energy. The exact how is still being figured out, but it probably involves things like oxidative stress and direct damage because of this energy shortage.
And does the chronic alcohol itself, separate from the deficiency, make it worse?
Seems likely yes. Chronic alcohol exposure can directly damage neurons too, especially in those same vulnerable areas like the thalamus and mammillary bodies. So you've potentially got the deficiency damage plus direct alcohol toxicity.
Can you actually see this damage on brain scans?
Often, yes. Neuroimaging, particularly MRI scans, can show structural changes. Things like cerebral atrophy shrinkage, especially in those key memory structures, mammillary bodies, thalamus, hypothalamus. You might also see the ventricles, the fluid spaces in the brain, looking larger than normal.
Okay, so we have the definition, the causes, risks, what's happening in the brain. But lots of things cause memory loss and confusion. How do doctors tell Korsakoff's apart from everything else? What are the main differential diagnoses?
Yeah, this is so important because the symptoms do overlap. You absolutely have to rule out other possibilities. Top of the list would be things like Alzheimer's disease, other types of dementia, maybe traumatic brain injury, or cognitive problems caused by other drugs, not just alcohol withdrawal.
And the notes had a pretty long list of other things to consider, too.
Oh, yeah, it's quite extensive, to be thorough. Things like wider drug misuse, alcoholic ketoacidosis, delirium tremens, the severe alcohol withdrawal state, general dementia, chronic lack of oxygen, head injuries, liver problems affecting the brain, hepatic encephalopathy, the confusion after a seizure, stroke, or other cerebrovascular disease, even brain tumors.
Wow, that's a lot to potentially rule out. Why is it so vital to pinpoint Korsakoff's specifically?
Because unlike many of those other conditions, especially degenerative dementias like Alzheimer's, Korsakoff's is potentially treatable, particularly if you catch it early in that Wernicke's phase. Getting the thiamine in can stop the damage, maybe even reverse some of it. That's just not the case for Alzheimer's.
That's a huge difference. Okay, how common is this condition? What's the epidemiology?
It's hard to get exact numbers, but it's definitely a significant problem, especially in certain groups. You see it most often in people with chronic alcoholism, usually middle-aged or older.
And it's a big chunk of alcohol-related brain damage overall.
A major part, yeah. Some estimates say alcohol-related brain damage accounts for something like 10 to 24% of all dementia cases. And worryingly, the incidence of Korsakoff syndrome seems to be going up.
Is it the same everywhere, or does it vary?
It varies quite a bit. Globally, prevalence is estimated maybe between 0 and 2%. It's definitely higher in more vulnerable populations, people experiencing homelessness, isolated older adults, psychiatric inpatients. And here's that really interesting point from the notes. Prevalence doesn't always match up neatly with how much alcohol a country consumes overall.
Wait, seriously? Higher alcohol consumption doesn't automatically mean more Korsakoff's.
Apparently not always. The notes gave examples like France having a prevalence around 0.4% versus Australia at maybe 3%. It's a bit puzzling, right? It suggests other factors are really important. Maybe things like how much thiamine is added to food, different drinking patterns, access to healthcare, maybe even genetic factors.
Huh. That difference alone really makes you think. Okay, so someone presents with suggestive symptoms, they have risk factors. How do doctors actually confirm it? What investigations get done?
It's about piecing together the clinical picture with some objective findings. Starts with a really careful medical history, focusing heavily on alcohol, diet, other risk factors.
Got to find that potential thiamine link. Makes sense.
Exactly. Then formal neuropsychological testing is really important. It gives objective measures of memory and other cognitive skills, helps map out exactly what the deficits are.
What about blood tests? Are they helpful?
Yes, blood tests are part of it. Direct thiamine levels can be a bit tricky. Sometimes they look normal, even if there's a deficiency in the tissues. But bloods are crucial for ruling out other causes and checking overall health, like liver function, especially with alcohol history, so things like LFTs, albumin levels. A full blood count, an FBC, can help rule out infections that might cause confusion, like HSV encephalitis.
So bloods help confirm some things, rule out others. And the imaging we talked about.
Yes, brain imaging is key. MRI is usually preferred. You're looking for those telltale structural changes, the shrinkage, the atrophy, the mammillary bodies, thalamus, hypothalamus, maybe those enlarged ventricles. Seeing that really strengthens the diagnosis.
Any other tests, maybe more invasive ones?
Occasionally. A lumbar puncture, a spinal tap, might be done if there's a strong suspicion of a brain infection that could be causing the symptoms. And an EEG that measures brain waves might be used to rule out certain types of seizures, like non-convulsive status epilepticus, which can sometimes just look like confusion.
Right, so it's a combination. History, cognitive tests, bloods, scans, maybe LP or EEG. Okay, now, the really crucial bit, management. Can this be treated? What do you do?
Treatment is absolutely vital, especially catching Wernicke's early. The absolute cornerstone, the number one thing, is thiamine replacement.
Just giving vitamin B1.
Yep, but usually in high doses to start. And often given intravenously or intramuscularly, IM, at first, this gets it into the system quickly and bypasses any potential gut absorption problems. Then that's typically followed by long-term oral thiamine tablets.
And if alcohol is the trigger?
Addressing the root cause is essential. If it's chronic alcoholism, then stopping drinking completely is critical. Absolutely crucial to prevent more damage and give the brain any chance to recover.
What about support beyond thiamine and stopping alcohol?
Oh, supportive care is huge because often there are lasting cognitive problems. This means things like rehabilitation programs, cognitive training, strategies to help manage the memory loss, and definitely psychological support for the patient and their family too.
The notes really stress that Wernicke'sencephalopathy is an emergency. How does treatment differ in that acute phase?
It's an emergency because giving thiamine right away, aggressively, can make a massive difference. It can improve the outcome and potentially stop it progressing to the chronic, often irreversible Korsakoff state. You're treating that acute confusion, the eye problems, the walking issues, urgently.
And there is that really important rule about giving thiamine.
Yes, crucial point. Give thiamine before giving glucose.
Why is that sequence so important? Before glucose?
Because metabolizing glucose actually uses up thiamine. If someone's already critically low, giving them glucose first can suddenly drain the tiny amount of thiamine they have left, potentially making the Wernicke symptoms acutely worse. The notes mention using high-potency IV preps, like Papernex in emergencies, and that oral thiamine needs to continue for a good while after maybe 3 to 12 months.
Okay. What about managing things long-term, especially since you said recovery can be patchy?
Yeah, long-term management often needs a whole team: doctors, nurses, therapists, social workers. Recovery is usually slow, often incomplete. Many people are left with prominent cognitive issues and need long-term care or significant support services tailored to what they need. A huge focus long-term is preventing it from happening again. So, ongoing thiamine, especially for anyone at risk, and definitely no alcohol if that was the cause.
And you mentioned legal stuff might come into play.
Yes, potentially. Depending on how severe the cognitive problems are and that lack of insight, legal things like the Mental Capacity Act might be needed to make sure decisions about care or finances are made in the person's best interest.
So, bottom line, stabilize acutely, hit them with thiamine fast, tackle the underlying cause like alcohol, and then plan for long-term support and prevention.
That sums it up pretty well. Pharma-wise, it's IV or IM thiamine in hospital, then oral, often with multivitamins ongoing. Dosing depends on severity. And if you're giving IV thiamine, you need to be somewhere equipped for rare allergic reactions, like anaphylaxis.
Right. Okay, we've gone through cause to treatment. What's the outlook? What's the prognosis typically like for someone with Korsakoff's?
It really varies a lot. Depends heavily on how bad the thiamine deficiency was, for how long any alcohol abuse went on, and basically how much brain damage happened before they got treatment.
Is there any good news in terms of recovery?
The best chance for improvement comes with spotting and treating Wernicke's really early and aggressively. But once Korsakoff's psychosis is properly established, well, full cognitive recovery is unfortunately quite rare.
So the deficits often stick around.
Yes, frequently. Especially the memory problems. They're often permanent. Staying off alcohol and taking thiamine long-term are vital, not necessarily to reverse the memory loss, but definitely to stop any more damage and prevent the Wernicke's part from coming back.
And what if that acute Wernicke's phase isn't treated?
That's got a really grim outlook. The notes mentioned a mortality rate up to 20%, and for those who survive, something like 85% go on to develop the chronic, disabling Korsakoff's psychosis.
Which just underlines how critical that emergency thiamine is. And for those who do develop Korsakoff's, what's the reality of long-term care?
The notes suggested up to a quarter, 25%, of people with Korsakoff syndrome end up needing long-term institutional care because their cognitive and functional problems are just too severe for them to manage independently.
That really highlights the devastating impact and the need for support, especially for vulnerable groups like people experiencing homelessness or those without good care networks.
Absolutely. Preventing B vitamin deficiency in those groups and making sure treatment for alcohol dependence is available are really important public health goals to try and reduce how much this happens. Having care plans in place for people at risk is key.
If recovery isn't complete or if it goes untreated, what are the main complications we see?
Well, the main complication of ongoing Korsakoff's is just significant disability in daily life and a really poor quality of life. The memory problems, the poor judgment, they increase the risk of other health issues too often because self-care suffers. Things like malnutrition, infections, maybe liver disease, heart problems.
And the cognitive issues must make them physically vulnerable too.
Oh, definitely. Severe amnesia, disorientation, lack of insight. It makes falls and accidents much more likely. It also makes navigating social situations really hard, leading to isolation.
And you said the biggest complication of untreated Wernicke's is just developing Korsakoff.
That's probably the single most significant consequence of not treating the acute phase properly, yes. And recovery from Wernicke's itself isn't guaranteed either. Only about 20% recover fully neurologically. Many are left with persistent walking problems, the ataxia, or eye movement issues, even if they don't progress fully to Korsakoff's memory loss. Recovery is often hampered by the direct toxic effects of alcohol, ongoing poor diet, and sadly, sometimes relapse into drinking.
Were there other complications listed?
Yeah, things like alcohol withdrawal symptoms if stopping drinking isn't managed well. Recurrences of Wernicke's are possible, especially if thiamine isn't continued and the underlying cause isn't fixed. And then those persistent issues like the ataxia and, of course, the core problem of ongoing learning difficulties and memory impairment that defines Korsakoff's.
It really does drive home how something seemingly simple, like a vitamin deficiency, often tangled up with complex issues like chronic alcohol use, can lead to such profound, life-altering changes.
It's a stark reminder of just how interconnected nutrition, brain function, and our overall health really are.
We've spent a lot of time talking about this profound memory loss. Can't make new memories, lose access to your own past, sometimes filling the gaps with things that aren't real but feel real. It really makes you stop and think, doesn't it? What actually makes up someone's identity when that connection to their own life story, their past and future, is so severely broken?
It definitely pushes up against some fundamental questions about self, memory, and consciousness.
It really does. Okay, so that was our deep dive into Korsakoff's psychosis and Wernicke-Korsakoff syndrome, working through those revision notes. We've hit the definition, the thiamine deficiency link, the progression from Wernicke's, the causes, risk factors, what happens in the brain, how it looks clinically with that striking amnesia and confabulation, how it's diagnosed, the absolute importance of quick treatment with thiamine, the often difficult prognosis, and the serious complications.
Yeah, hopefully breaking it down like this has helped make sense of it all, giving you that high-yield understanding. Because understanding conditions like this, the connections between, say, diet and brain function, it's just so important.
Absolutely. Whether you're revising this stuff or just trying to understand it better, having that clear picture is crucial.
And look, if you are doing revision, particularly for medical exams, or just want more solid resources, don't forget passthemsra.com and freemsra.com. They're great spots to build on what we've talked about today.